what I'm going to talk to you about is a very important clinical topic, that is perioperative use of SGLT2 inhibitors, with specific focus on some recent guidelines and updates on the same. So if you see the current guidelines, US FDA talks about this, that currently the guidelines suggest that you need to stop canagliflozin, DEPA and EMPA, and a recent bexagliflozin, which is available in the US, not available in India right now, 3 days before surgery. And you need to stop ertugliflozin, again not available in India, 4 days before surgery. This is the current US FDA recommendation. This is there printed in the label of the SGLT2 inhibitors. Now, why is this recommendation there? What is the basis of this recommendation? Now, the basis is typically the half-life of SGLT2 inhibitor is 11 to 13 hours. So, what they are saying is that you need to stop the medication at least 5 days before the half-life, right? So, at least for the 5 half-life. So, you're looking at more than 5 half-life guidelines recommendation. And why is this important? Because of the risk of a very important problem, which is called euglycemic ketoacidosis. I'm going to talk to you about this. How many of you have seen cases of euglycemic ketoacidosis? I think Vivek would have seen, Sir would have seen, right? So, the problem is, it's a very bad issue, but you can easily prevent it. And when we started using SGLT2 inhibitors, I remember we had seen back-to-back 4 or 5 cases with the early use of SGLT2 inhibitors. So there are a lot of patients coming up early. Now, of course, you have a lot of clinicians who are aware of this problem, and because of that, we don't see those cases very frequently. But again, if you have colleagues from anesthesia, again, this is something which you need to be very well aware about. So there is now a specific terminology which is called SGLT2 inhibitor associated perioperative ketoacidosis. Instead of the using of the term euglycemic ketoacidosis, there is a term called SEPCA, right? So it's SGLT2 inhibitor associated perioperative ketoacidosis. There's a very specific term for that. The point that this is so common, this is the reason which has led to this. And so during the perioperative period, which period of time does it really happen more frequently? It generally occurs in the post-operative period, right? I'll again talk to you about specific time when this problem really occurs. And the point really I was trying to make is, at what point of time is it very common? You can see, how common is it? If you see the data from 2014 to 2021, you can see the number of reported cases. These are the cases reported in literature. The number of cases reported, 2014, 0 cases of euglycemic ketoacidosis perioperatively, and you can see almost 25 to 30 cases reported recently in 2021, right? So the numbers are increasing. So it's a problem which we all need to be aware about. It could have medical legal consequences also, so something we need to be very well about. So what exactly is euglycemic ketoacidosis? I'll talk to you about a case. So I remember a patient who underwent a cardiothoracic surgery, CABG, and this was a diabetic patient on multiple medications, had seen a cardiologist also, and this is about maybe 2-3 years back, somewhere in 2000, pre-COVID. So I get a frantic call from the cardiac anesthetist saying that, a patient hai, you need to see urgently. I said, fine, what's the issue? So the cardiac anesthetist was saying that this is a patient who was diabetic, and post-operatively, we had a difficulty weaning off the patient. And when we started checking the parameters, it turns out that the patient had metabolic acidosis. Then we looked at the anion gap, and the anion gap was high. And immediately it struck to us, it could be euglycemic ketoacidosis. And we checked the beta hydroxybutyrate and the acetone levels, and both of them were high. So what this patient had was what is quintessentially known as euglycemic ketoacidosis. And then we treated the patient. Patient was weaned off from the ventilator, and the patient, became better, and then we could discharge the patient, right? So it's a common issue. Again, within the same week, I remember that week very fondly because, not fondly rather, but remember it very distinctly because I got a call from Zydus Hospital, Anand, with exactly the same issue, right? Another patient who had undergone a CABG, and the patient had post-operative issues, and both the anesthetists talked with each other and they said, "Omne phone karo," right? So this is exactly the same problem was recognized a few weeks, a week later from another hospital, network hospital in the thing, right? So euglycemic ketoacidosis is when you have, it's difficult to recognize because the blood sugars are often normal, right? So by definition, the RBS random sugar is less than 252. The pH is less than 7.3. You have metabolic acidosis with bicarb less than 15. But the important parameter, and you'll see this being used frequently by me in rest of the talk, is the use of anion gap. And anion gap is more than 12. Right? So what is anion gap? Anion gap technically by definition is sodium plus potassium minus bicarbonate plus chloride. Some definitions don't use potassium, so you can skip potassium. So it's sodium minus bicarbonate plus chloride. Typically, the anion gap should be less than 10. Anything more than 12 is considered significantly high, and you would have heard the term high anion gap metabolic acidosis. Two very important differential diagnoses of high anion gap metabolic acidosis related with diabetes is one is diabetic ketoacidosis and other is lactic acidosis. So both the things you have to be very well aware when you are dealing with such patients, right? So this is something which is very important, and hence because the random sugars are often normal, you need to see the anion gap, and that's why anion gap is something which is very useful in this situation. So in fact, you can, when you have an ABG parameter, when you have ABG analysis being done, anion gap is given in the ABG parameters also. But technically, you don't need to send a ABG. You can also send a venous blood glucose, and by checking the venous venous blood gas analysis, a venous blood gas analysis will also give you the anion gap. So apart from checking the anion gap, a lot of you, let me get you back to your biochemistry days. A very important test which again we should consider doing is beta hydroxybutyrate. Beta hydroxybutyrate is better than acetone. Remember, again, if you learn biochemistry, if you see the evolution of the ketones in diabetic ketoacidosis, what typically happens is initially the acetone level comes high, then the acetone levels drop, but the patient is still having ketoacidosis and the acetone level increases again. But beta hydroxybutyrate is actual ketone body where the levels are constant and they match with the clinical situation. So if you, now this test is easily available. In fact, if you are using a there are certain glucometers also which have ketone measuring also, like for example Optium from Abbott has a ketone measuring device also, and that measures the beta hydroxybutyrate. So now we have these tests available. If you don't have the test available in your lab, you can buy the meter, right, and you can buy the ketone strips. They are easily available from Abbott, right? You can buy those and you can use it in your clinical practice day in day out. So by definition, beta hydroxybutyrate more than 2 millimoles per liter is considered to be high. And more than 20 milligram, so if that 2 millimole is converted to milligram per deciliter, it's more than 20 milligram per deciliter. So if you are using, my laboratory uses milligram per deciliter, my meter uses millimoles per liter. So again, if you want to do that conversion, it is 1:10, okay. So why do SGLT2 inhibitor predispose to diabetic ketoacidosis? This, in fact, one of the earliest complications recognized with SGLT2 inhibitor was diabetic ketoacidosis. And why does this happen? Well, SGLT2 inhibitor definitely lead to glycosuria, we know that. Along with that, remember, you are dealing with a situation where there is physiological stress and the patient is in a fasting state, right, perioperatively. So all these things lead to, because you have glycosuria, you have increased, glucose is being lost in the urine, the body produces more glucagon, right, and more noradrenaline. Physiological stress adds to noradrenaline and glucagon release. And the fasting state leads to, because the patient is fasting, the insulin secretion is reduced. So you have reduced insulin secretion. And some of these patients with a long-standing diabetes already have a poor beta cell function. So they have reduced insulin secretion. So all this in combination. Remember, one thing you should also teach your MBBS students. When do you develop diabetic ketoacidosis? When you have low insulin and more glucagon, right? So whenever you have a situation where you have low insulin and high glucagon, that leads to ketogenesis. There are patients with pancreatic diabetes who don't develop diabetic ketoacidosis ever because they have low insulin and low glucagon. But certain patients like this who have low insulin and high glucagon, like your type 1 patients or like your ketosis prone type 2 patients, they develop diabetic ketoacidosis because of this type of clinical picture, right? So this is what leads to perioperative diabetic ketoacidosis. The other issue is, and this is now recently recognized, that when you give SGLT2 inhibitor along with the reabsorption of glucose, they also reabsorb ketone bodies, which is very interesting. So you have ketone which is lost in the urine, body is trying to remove the ketone, but the SGLT2 reabsorbs the ketone, and hence you have higher ketone levels in the blood. Again, SGLT2 inhibitor, we already discussed this, SGLT2 inhibitor. So if you talk about drugs, and today we are talking about SGLT2 with DPP4 combination, very interesting clinical point we should all remember. SGLT2 inhibitors increase the glucagon level, whereas DPP4 inhibitors reduce the glucagon level. So SGLT2 inhibitors increases risk of ketoacidosis, whereas DPP4 reduce the risk of ketoacidosis. So when you give this drug in combination, you have less episodes of ketoacidosis. In fact, this has been proven in a paper, right? Where they looked at SGLT2 versus SGLT2 with DPP4 in combination. They actually measured the glucagon level and risk of ketoacidosis. They actually found that patients with combination had less ketoacidosis, which is interesting, right? So how do you recognize, how do you know that the patient is euglycemic ketoacidosis? Your anesthetist or your intensivist needs to be aware of this, right? Whether you are aware or not doesn't matter, but perioperatively your anesthetist should be aware of this. Sometimes the symptoms are very subtle, right? So you have sometimes respiratory distress. Patient, you are not able to wean off from the ventilator. You have gastrointestinal disturbances. The patient can have nausea, vomiting, excessive vomiting, and a very subtle clinical symptom is malaise, tiredness, right? So a lot of our patients will complain of tiredness. I'm sure if I had a rupee for every time a patient on SGLT2 complains of tiredness, well, I would probably have a lot of money for sure, right? The thing is, tiredness is very common with SGLT2, and sometimes subtle tiredness you should look for ketoacidosis as a potential problem, right? So these things are very, very important, right? So what type of so there is a recent paper where they looked at all the reported cases of diabetic ketoacidosis because of SGLT2, and what they found was what type of surgery it is generally seen is very commonly seen in bariatric surgery, right? When does it generally diagnose? Like I said, 25% of the cases are diagnosed on postoperative day 1. So it is more common postoperatively, and that is something you should be all well aware. How do you trigger? What is the trigger for identification? Most of the time you have subtle clinical symptoms, and most of the time diagnosis was made with lab analysis rather than by clinical symptoms. So again, you should be aware. In terms of symptoms, a lot of these patients had shortness of breath and dyspnea, which was a trigger. Also unexplained tachycardia and tachypnea. The second patient in Anand I talked to you about, the anesthetist was well aware of this. They looked at the patient had persistent tachycardia, and hence they decided to have a look. And very importantly, you need to check the blood ketones and the anion gap. And if you see this paper where they collected all the data, typically the beta-hydroxybutyrate level was 5.8. I told you more than 2 is considered significant. And mean anion gap was 23. More than 12 is considered significant. So typically you will find values of these kind of thing. pH was 7.1 and ranged from 6.8 to 7.2 in this paper. So now comes the most important part. How do you manage? What is the perioperative management protocol for SGLT2 inhibitor? I think you should all be aware of this. Like I said, you have to be very careful because this could be triggers for potential medico-legal issues also. So if the patient has SGLT2 inhibitor, now there could be 2 scenarios. Patient is having diabetes, and believe you me, patient may not have diabetes, right? You already asked, Dr. Vivek of this question. Remember, non-diabetic patients may also be prescribed SGLT2 inhibitor. For example, patient could be prescribed SGLT2 for heart failure or maybe for chronic kidney disease, or off-label sometimes for weight loss and other problems, right? So these things you have to be aware. But interestingly and thankfully, patient not having diabetes, there has been only one reported case, just one reported case of diabetic ketoacidosis. But mostly, if the patient is prescribed SGLT2 not for diabetes, for other indications, you generally don't need to worry about, and you can actually go ahead with surgery, right? So if it is a non-diabetic patient, it is fine. But again, be careful. Sometimes you could have a patient who was diagnosed with diabetes, it was not known or whatever, then you have to be again careful. If the patient has diabetes, you have 2 scenarios obviously. Either you have a situation where you are going for an emergency surgery, or it could be an elective surgery. Let's look at both the scenarios. What if the patient comes for an emergency surgery, right? So whenever the patient comes for emergency surgery and the patient is on SGLT2 inhibitor, there are 2 tests we should do in all of your patients. One is anion gap and second is beta-hydroxybutyrate level. If the anion gap is more than 12 and beta-hydroxybutyrate is more than 2, in such situation you talk to the anesthetist and say or the surgeon and say, can you defer this surgery? Because if you have anion gap more than 12, patient is already in ketoacidosis before the surgery. You are going to make the patient worse, right? So you need to discuss the pros and cons of surgery with your surgeon. If the surgery can be deferred, yes, then admit the patient in the ICU and treat the diabetic ketoacidosis first. If the surgery cannot be deferred, or if the values are normal, still start the patient on an insulin infusion with plus minus dextrose. If the glucose is more than 250, give normal saline. If the glucose is less than 250, it is better to give dextrose containing fluid, right? So this is the outcome. And then all of these patients should be told that surgery is under high risk, okay? When you have an emergency surgery with a patient on a Yeah. And then let's look at an elective surgery situation. So in an elective surgery, as per the US FDA guidelines, you have to stop the SGLT2 inhibitor 3 to 4 days before surgery. If the patient comes, if the patient consulted you before the surgery 3-4 days back and you stop the drug and after 3-4 days you are gone for surgery, you can go ahead with surgery. There is no problem. You have followed the rules properly, not an issue. But if this is not done, patient suddenly turns up on the day of surgery and patient is still taking the medicine, that is where again you need to check the anion gap and beta-hydroxybutyrate. If the anion gap is more than 12 or beta-hydroxybutyrate more than 2, then cancels the surgery. Patient is already having ketoacidosis before surgery, treat the decay. But if it is not the case, then you can again start the insulin infusion plus minus dextrose and again tell the patient this is surgery under high risk, right? Because remember, the SEPTA cases, SGLT2 inhibitor ketoacidosis occurs after surgery, post-operative day 1. So again, you need to be careful about this. What do you do intraoperatively in such patients? Monitor the blood glucose and give insulin infusion. Again, dextrose if blood glucose is less than 200 or 250, right? Again, this is for anesthetists to maintain. We are generally not involved in that. What should you do post-operatively? Again, very important. It is a very good idea to check the anion gap post-operatively. Now, again, there could be a situation where sometimes, you have a daycare surgery where patient is going to be discharged immediately. Now, if the patient is to be immediately discharged, again, before discharge, check the anion gap and check the blood glucose, right? Because sometimes what will happen is the patient is in ketosis, you discharge the patient and after 1 day patient comes in a bad state. So before discharge, you should consider checking and make sure that the patient is not in ketoacidosis before discharge. Remember, glucose will not tell you ketoacidosis, it is euglycemic. Patient's glucose may be normal. That is something I am repeatedly saying, you need to be very careful. After the day of surgery, if the patient can take orally, right, try to initiate oral intake faster, right? Because if you have faster oral intake, the patient is less likely to develop ketoacidosis. And again, keep checking the anion gap. We are coming to this again and again. The best test to do in this situation is anion gap, right? That's the most efficient test for making the diagnosis. So keep checking anion gap every 4 to 12 hours in such situation. Now, there are certain surgeries where there is high risk of ketoacidosis and certain surgery where there is low risk. So if you talk about low risk situation, when you have a short GA or less than 1 hour or local anesthesia, then it's fine. When anticipated nil by mouth duration is less than 12 hours, preoperatively HbA1c is less than 8%, preoperative blood glucose is less than 150, the patient is not on insulin as outpatient and there is no significant background comorbidity. In all this situation, it can be considered to be low risk. But in high risk situations are those where you have more than 1 hour of surgery, where the NPO duration is going to be more than 12 hours, where HbA1c pre-op was more than 8%, blood glucose pre-op was more than 150, patient was already on insulin pre-operatively, and patient has other significant comorbidities. All these things are considered to be high risk. How do you manage euglycemic ketoacidosis? It's very straightforward. It is just like diabetic ketoacidosis management, just the same guidelines. Only thing is you have to, because the sugars are relatively low, you can, instead of giving, you just need to switch your fluid. That's all thing you have to do. Stop any inciting agent. If the patient is on SGLT2, stop it. Start fluid replacement, electrolytes, ketones monitoring, continuous glucose insulin infusion, and dextrose infusion if the patient has glucose less than 250, right? So this is something you have to be careful. Again, let me tell you, sometimes what happens is the effect of SGLT2 starts going and the blood glucose can start rising, right? So again, you have to be careful and again switch the IV fluid depending on the situation. A very interesting thing, I was just again looking at more papers, and another recent paper actually used somatostatin for a patient with very severe euglycemic ketoacidosis. Patient was morbid and the patient actually improved, right? Now this is very interesting. I'm sure none of us has used somatostatin for diabetic ketoacidosis, but in 1980s, this was actually proposed as one of the treatment for diabetic ketoacidosis. Even I didn't know that, right? This is something which is very interesting to me. So in this case, their patient did not improve after the usual care and they gave somatostatin and actually patient improved. The theory is basically somatostatin reduces glucagon level, right? It actually reduces both insulin and glucagon, but insulin to MB ochu hai, so you don't have to worry, right? Now you are basically worried about glucagon, so you're reducing the glucagon level, and by reducing glucagon level, you improve the chances of patient going into improvement. Now, having said that, don't start using somatostatin in all your patients, because as such somatostatin now availability is also a problem. We often use octreotide, which is a somatostatin analog, and if you take about data from octreotide, generally the data is mixed. Most of the time, there are several papers which have shown little or no benefit of use of octreotide in diabetic ketoacidosis. There is just one paper which says that it prevents the recurrence of diabetic ketoacidosis in some of these patients. But having said that, the data is pretty much minimum, and you should not consider using it in routine patients. But if you have a patient with euglycemic ketoacidosis which is perhaps morbidant and you have tried your best and the patient is not improving, perhaps you could consider using this as a treatment, because there is now a recent paper, one paper showing benefit, right? So, if you want more detail, these are the 7 references we have used for our presentation. You can have a look at this, and you can take a screenshot. I mean, you can take a photo of